There
All
you
right,
are.
and I can see you. Good deal. Let's go ahead and disconnect the phone call and talk via Skype.
All right.
All right.
Very good. Hi, Terrence. Can you hear me?
Hey, I
Yeah, I
can. Good
can.
morning, Dr. Kelly.
How are you doing?
I'm great. We're already recording. I'm going to turn your volume up a little bit so I can hear you loud and clear, and I
Okay.
want everyone who was watching us to hear you as well. Um, you're coming through great. I can see you fine. I think other folks can
Okay.
see you as
Very good.
well. All right, let's make this happen. Well, first of all, Doctor, it's a pleasure to see you this morning. Thank you for taking time to talk with us. We have a room full of folks right now at the North Carolina Recovery Advocacy Alliance Summit who have been eager to hear from you. I think you know a little bit about what this alliance is all about, but just in sort of to recap or rehash, this is really about trying to really bring together organizations that involve men and women who are seeking recovery from maybe a less traditional path. People who have some area of coercion, drug courts like I represent, and professionals who have become impaired and are a part of professional monitoring organizations, and young people who are part of collegiate recovery organizations. We have sort of this vision of the organizations and the individuals who live in these sort of three separate worlds, finding ways to work together to support long-term recovery among those who we service. And as I'm certain is no surprise to you, sometimes we at some point in the lifespan service the same individuals. So we're looking for ways to connect and interact. And I want to talk with you some about your thoughts about that and whether this vision we have of a sort of a seamless transition, all with addiction treatment and recovery resources, being sort of the hub, but these various paths somehow being well coordinated. For those who are watching this interview, most of you know who Dr. John Kelly is, but just for those who may not, he is the Elizabeth R. Spallin Associate Professor of Psychiatry and Addiction Medicine at Harvard Medical School. He is also founder and director of the Recovery Research Institute at Massachusetts General Hospital, the program director of the Addiction and Recovery Management Services, and the associate director of the Center for Addiction Medicine at Massachusetts General. He has written and researched extensively on treatment and recovery. He's one of the folks that we look to help us figure out, sort of where we are and what's next in the long-term recovery and professional treatment field. So, thank you, Dr. Kelly, for being with us.
Oh, my pleasure. Thank you for having me.
All right, so I guess I want to begin sort of this way. I talked a little bit about this vision that we have about taking professional monitoring organizations and drug courts and collegiate recovery organizations and finding ways, things we have in common, in ways to better connect and integrate and make the most of the leverage and the strengths we bring to the table. But what are your thoughts about that?
Well, it's a great goal. I mean, obviously, the more coordinated and the more aware of one another all of these different treatment and recovery support services are, then the greater chance that people will make better referrals, be able to educate and inform individuals who are in or seeking recovery so that they can, and the administrators who run those programs, so that they're aware of what the strengths and resources are that are available. Historically, all of these entities have been siloed. It's kind of natural for each one to develop and be focused more inwards as people are developing these programs. But then, as we look in the landscape of recovery potential, we want to be able to connect the dots, identify what the dots are, and then connect them. And that's always the challenge. It's always the challenge in kind of being able to create a recovery-oriented system. That's what we really want to do, is create a fabric, a continuous fabric, as it were, um, that people can use to facilitate recovery long term. We do know that even after many years of remission, full sustained remission from substance use disorders, that people are still susceptible to relapse. It doesn't, it takes about 5 years until the risk of relapse drops below, in the following year, drops below 15%, which is the risk in the general population for meeting criteria for a substance use disorder. So to be no more likely than anybody else to meet criteria for a substance use disorder in the next year takes about 5 years of sustained continuous remission. So we're talking about a disorder which requires ongoing monitoring and management over the long term. And even after 5 years, of course, it doesn't mean that you're cured.
Sure.
It just means that you're in remission, you're stably in remission, and the statistical odds of you relapsing are low. They're no higher than anybody else in the general population who has no history of a substance use disorder.
Okay.
So all of that suggests that we need, recovery support services over the long term, even when people are in stable remission.
Okay. Well, that's very helpful insight, and I think that is, what you just described there is something that certain research has taught us, but many of us as practitioners, we've observed that as well. It intuitively makes sense to us, and it's among the reasons why we're trying to come together to figure out how we do as much as we can to support people, especially during those initial 5 years and beyond. I'm wondering about the state of research, Dr. Kelly. The state of research, not as it relates to professional treatment, but the state of research as it relates to long-term recovery, recovery-oriented systems of care, all of these ideas and these concepts that have arisen as we try and do a better job at sustaining people in the long-term recovery. What is the state of research? What's out there? What are the gaps? Where are we?
It's a great question. It's just been writing. Thankfully, we have the new U.S. Surgeon General report coming out hopefully this year, and on alcohol, drugs, and health. So it's looking at substance use addiction and recovery. For the first time, we'll include recovery, and we've been writing a chapter for that on recovery, which has been fantastic. But as a result of that, we've been actually reviewing the research on all of these treatment and recovery support services for addiction. And on the recovery end of things, most of the research has really been done on mutual help organizations and mostly on AA, and not much else. In terms of other recovery supports, very little has been done. There's been very little done on collegiate recovery support programs, very little done on professional monitoring organizations, outcomes, some, but not a lot. There's been some evidence, some research done on recovery housing. So these would be like Oxford houses, and looking at those as long-term models of care, residential communities where people are staying in sober living over the long term and looking at the effects and cost effectiveness. But there's been a little bit of study on recovery high schools, and a little bit on drug courts, but not a lot. So it's kind of an emerging area, and overall, in terms of looking at the city, at the region level, and looking at how kind of these recovery-oriented systems, when implemented, actually affect rates of recovery and even prevention. When you have a lot of these resources densely in communities, does that actually affect the rates of onset of substance use disorder as well as recovery? So all of these questions need, we're kind of at the cusp, I think, of a greater emphasis on recovery-oriented services and how do we keep people in remission and in recovery over the long term. Because we've done a ton of stuff on treatment, tons of studies on treatment and trying to identify, what are the effective components of treatment on the acute care side, but very little, relatively speaking, on the long-term management side. So we've got a lot to do there.
Okay.
Yeah. Lots of opportunity.
Yeah. Well, is anything on the horizon? Is there research ongoing or things that are on the horizon that we should know about?
Well, one of the studies I'm doing right now is it's a National Institutes of Health funded study looking at recovery community centers. So we have started that. We're in year 2 now. We're looking at all the recovery community centers around New England and New York State, about 40 centers. We're looking at characterizing them, evaluating their public health and clinical utility as they relate to recovery support. So these are, as you may know, these are hubs in the hearts of communities that are affected by alcohol and other drug problems. It's a place, identifiable place where people can go and get access to emotional and instrumental support in terms of identifying links to employers, how to put a CV together, a cover letter, get support through social services, get linkages to those. So they're great hubs, but we just don't know much about them. So that's one bit of good news, is that NIH is now funding these studies on recovery support services. Another one, which I'm working on to submit along with a group across the country, a national study is on recovery high schools, which we're hoping to do another 5-year follow-up study examining the potential of recovery high schools to have an effect on young people, get them into recovery. There are studies underway that are looking at collegiate recovery programs as well. And we need much more of these types of studies, however. So there's just a few examples. We are about to submit another study to look at smart recovery. So smart recovery is a non-12-step mutual help organization which is emerging and growing around the country and around the world, which again can provide another pathway for individuals who are seeking recovery to support recovery in a different way than 12-step does. So there are emerging avenues of research, but I think we're just at really the beginning of this focus on recovery. The good news I've heard from NIH is that both NIDA and National Institute of Alcohol Abuse and Alcoholism are very interested in supporting recovery research. So that's good news.
Well, that is good news. And Dr. Kelly, thank you for mentioning smart recovery. You've reminded me that we had several questions from people who are in attendance today for you, and several of them involve smart recovery and the dominance of the very valuable 12-step fellowships that the professional treatment community has come to rely on to help support long-term recovery. But there was some concern raised about whether the 12-step fellowships have become exclusively dominant at the expense of smart recovery, which, at least from those who wrote, said they've experienced anecdotally some real good results from people who are there. I mean, is there a real conflict here? Is there room for both? What are your and what are your thoughts on that?
Yeah, it's an important question. I mean, I think what we do know is that recovery, we want to facilitate recovery by any and all means necessary. We know that people choose different pathways to recovery. So many people choose the 12-step recovery option, but there are other pathways that people follow that we need to support as well. And there are a variety of mutual help organizations based in different philosophies. SMART is one of them. There's LifeRing, Secular Organization for Sobriety, Women for Sobriety, Moderation Management, which is the only one that really addresses kind of moderation as opposed to abstinence. So there are many different organizations out there. One of the problems with the others, I mean, for sure, the landscape has been dominated by 12-step just because it's been around the longest, it's grown the fastest. I mean, there are, tens of thousands, 70 or 80,000 NA and AA meetings around the country, but, about 500 smart recovery meetings around the country. So there's far fewer of these other meeting types, other fellowship types, organization types. And part of the problem has been that because they have, it's kind of like a vicious circle, catch-22, where these other organizations, because they're small, clinicians tend not to refer to them, because there are so few of them. And of course, because clinicians are not referring to them, patients to them, then they're not growing. And so oftentimes, because they're small, it's harder to get funding to study them because people will say, well, they're too small. But of course, if you don't study them and actually get publications out and start to document their potential effectiveness, then they're unlikely to get on the radar screen of clinicians.
Right.
So it's a bit of a vicious circle, isn't it? In terms of that. So that's what we're trying to do right now is to raise consciousness around these other avenues of support that people do choose, they do get involved in. And I think if they were more widespread and more available and shown to be effective in the ways that 12-step organizations have shown to be effective, which I think they probably will be shown to be effective, these other ones, in similar ways, because they run in similar formats principally, that we could get more people into recovery, and that's really the goal.
Yeah, well, that makes sense to me. I remember as a practitioner doing addiction treatment that we use smart recovery some, but almost exclusively because there weren't a face-to-face meetings, exclusively by encouraging our participants to do the online meetings. So when you think about things like online meetings or other distance, non-face-to-face, internet-based ways of either delivering addiction treatment services or recovery support services, is there anything we know from research or maybe even expert consensus about the effectiveness of these non-face-to-face approaches? I just, it's the wave of the future. It's what all it's what this generation does. But I wonder, do we know anything about its value and usefulness relative to face-to-face services?
Very little. Very little is the answer. And yet, these kind of technological approaches are much more available now. So again, it's kind of, these are questions which need to be asked and answered properly through proper research and evaluation. But they hold potential. I think, again, there are moderators, in other words, for people, obviously, they're better at maintaining as opposed to being a primary treatment, in terms of an online resource versus face-to-face. And so they may be better at maintaining recovery over time as opposed to initiating recovery for many, especially for people on the more severe end of the spectrum. They're going to need face-to-face evaluation and communication face-to-face, I think. And I think that the data support that.
Okay.
But for maintenance and for ongoing care, telemedicine is an emerging medium that people are using to access and reach people in rural areas where there are non-specialists available to support them on the medical front or the recovery disease management front. These are the kinds of technologies that could be used more broadly, widespread for addiction recovery support, and tested out. So there's lots of potential there.
Yeah. Dr. Kelly, I just looked at the clock and been terrified to realize we are almost out of time. I feel like we just started talking. So let me get a couple more in that that we can't miss. You've been really frank about the state of research when it comes to recovery oriented services, and so I guess as I sit here, talking to you today, I know that there's a lot of people in the room watching right now who are actively working to connect their organizations and systems and the men, women, and young people they serve with recovery support services and recovery centers, embracing peer coaching and all of the things that come with this recovery, long-term recovery orientation. Should we be concerned that we're doing that without hard research, or do we know enough in terms of the principles of what should work to safely proceed with trying to aggressively make this happen? Does my question make sense?
Yeah, I mean, the question is, of course, what do we do before there's
right.
efficacy and effectiveness studies? And of course, our clinical activity and our research recovery support activities are always way ahead of the research. Because people are innovating all the time. People are coming up with smart ideas, and they're implementing them because they need to help people right now. And this is critically important. And so just because we don't have research on something does not mean it doesn't work. It may work extremely well. It just hasn't been formally tested and evaluated. So I think, I think there's so many good recovery support specialists and treatment providers out there doing fantastic work every single day, innovating at the front line and doing new things to help more people, which is just fabulous. And I think, most individuals who are doing this day in and day out know the kinds of things that are helpful.
Yeah.
And there are principles. I think one of them is this idea of chronic recovery management or chronic disease management, is treating it as a chronic illness. That means, when people are stabilized, having regular checkups with people, much like you would have checkups with somebody who had diabetes or hypertension. You would be checking in with them, even if things are going well. You check in with them every quarter, just to see how things are going, make sure everything is continuing to go well. I think one of the things that we know with addiction in particular is the need for more assertive outreach.
Yeah.
So being more assertive, reaching out to individuals in recovery, keeping them on the radar screen so that they can be reached out to. And this is kind of one of the ways I think that the Physicians Health Program, professional monitoring organizations works, in that they keep monitoring people over the long term, and it's that monitoring and checkups that can help people stay on track. Much like if you had a team coach or recovery coach in the recovery world, a coach that can keep you on track, keep you on target in terms of your recovery. Other principles, of course, are being empathic, being patient with people, not kicking people out of treatment or recovery support services because they're confirming their diagnosis when they relapse, but rather to increase support rather than diminish support for individuals who are struggling. Because what that really tells us, if people are still struggling, still relapsing, is that we're not providing the right level of care or the right type of treatment for them at that particular stage. Sure. So we need to adjust our plan to help them better. So I think there are principles that we can bring to bear on this, Terrence, in the absence of formal research, for sure.
Well, that's very helpful. And I guess I've got a ton of other questions, but really only time for one more. Dr. Kelly, I'm holding in my hand an article that you co-authored that was printed in the Alcoholism Treatment Quarterly, I think just earlier this year, called Language, Substance Use Disorders, and Policy, the Need to Reach Consensus on an Addictionary. It's a fascinating read. Can you tell us about the article and what you think we ought to know when it comes to the language of addiction, recovery, and similar matters?
Mm-hmm. Yeah, great. Well, it turns out that language is very powerful, much more powerful than I ever thought before going into this area, more formally investigating it. And our language actually, because it both informs and it guides, but it also reflects our attitudes towards different disorders, and it's very important, the language that we use. Just to be brief, we found that, for example, certain terms, when we use certain terms, it can actually induce biases, implicit cognitive biases, make people's attitudes more punitive towards individuals who are suffering from a substance use disorder. And we tested this out formally. I've been doing this now for about 10 years in this particular area of research. But we actually tested it out experimentally, where we found that when people are exposed at random to a description of the same individual, but described as an abuser, as a substance abuser, as opposed to having a substance use disorder, they have substantially more punitive attitudes towards that same individual just purely by being exposed to that label. Now, what's interesting to me is that even though we don't mean harm, when we're in the habit of using language, and I was looking back at my first paper that I published in 2000, the year 2000, I was using the term substance abuser back then. I had no intention of, being negative. I was always, trying to help, trying to do the right thing. But using that terminology, I came to realize actually tends to induce these implicit cognitive biases against people with substance use disorder, making it more likely that they would be punished as opposed to treated. So in short, we need to get rid of terms like use, like abuser, and start using person first language and terms like substance use disorder, just because they reflect more of a medical malfunction rather than a volitional, willful misconduct.
Well, that certainly makes sense, and it's rich. I encourage folks to get the article. We can talk more about it in the room, folks, after this interview is complete. Listen, it has been a pleasure to talk with you. I know you were very busy and doing great work out there, and we're just honored that you took this time to share some of your insight and experience with us.
My pleasure, Terrence. Thank you for having me. Thanks, everybody.
Thank you, Doc.
Thank you.